Welcome back to the deep dive. Today we're pulling back the curtain on something surprisingly common, but often hidden away because, well, it's embarrassing. Urinary incontinence, or UI. We're diving into how it's evaluated and classified. And if you've ever thought this was just one single problem, well, you're about to see it's actually a pretty complex clinical roadmap. This isn't just academic. UI really impacts people's lives, their physical and psychological well-being. So understanding this diagnostic path is, I think, really key for you.
Absolutely. Our mission today is basically to hand you that roadmap. We want to show you the structured approach clinicians take, starting with, initial triage, ruling out the immediate acute stuff, and then moving all the way to accurately classifying the specific type. We'll be focusing on the 5 main players: stress, urgency, mixed, overflow, and functional incontinence.
Okay, let's unpack this then. Before we even get to labeling those chronic types, you're saying the evaluation has to start by clearing the decks, ruling out a couple of primary potentially acute issues.
Precisely. Step 1. Check for pregnancy.
Mm-hmm.
That's usually just an HCG test. It's crucial because incontinence is super common in the 2nd and 3rd trimesters. Often it's just the physical pressure, the uterus pressing down.
Yeah.
But, and this is often missed, pregnant patients are also at higher risk for UTIs, which brings us right to step 2.
Right. Step 2 being checking for a urinary tract infection, a UTI, with a urinalysis. So we're looking for that sudden onset of leakage, maybe paired with symptoms like pain when urinating or feeling like you constantly have to go, that sort of thing.
Exactly. Dysuria, urgency, frequency, sometimes even tenderness right over the pubic bone. And the urinalysis is like our chemical alarm system. We're looking for those telltale signs, nitrites, leukocyte esterase things that signal bacteria and the body's response. That confirms the infection.
Okay, so if those markers are positive, you treat the infection first. Seems pretty straightforward.
It mostly is, but here's a really important clinical pearl for you. If the leakage continues even after the UTI is successfully treated, after the antibiotics are done, you have to keep evaluating. The UTI might just have been masking an underlying chronic type of UI. So if the urinalysis is negative, or if leakage persists post-treatment, then we move on to classifying the chronic types.
Got it. So cleared the acute causes, negative urinalysis. Now we're into the chronic territory. Let's start with the most common one, I believe. Stress, urinary incontinence, SUI. This is all about physics, right?
Pretty much. The name really says it all. It's that involuntary loss of urine, specifically when there's physical stress or exertion.
Yeah.
Think about anything that suddenly increases pressure inside the abdomen, like coughing, sneezing, laughing hard, even lifting something heavy.
And the risk factors make sense too then. Things like previous pregnancies, especially difficult ones, maybe chronic constipation, putting strain down there, or obesity adding pressure.
Exactly. And on physical exam, you might see related things like pelvic organ prolapse, maybe cystocele, where the bladder pushes into the vagina, or just general pelvic muscle weakness. Now, to actually confirm SUI, we have a pretty clear diagnostic sequence. First up is the cough stress test.
Okay, what does that involve?
It's actually quite simple. You just observe if there's leakage when the patient coughs, usually done with a reasonably full bladder, maybe while they're standing up. Second, we measure the post-void residual, or PVR. That's how much urine is left in the bladder right after they've tried to empty it. We use ultrasound or sometimes a quick catheterization. And for SUI, the PVR is a key filter. We expect it to be normal. Generally, that means less than about 150 milliliters left behind.
Okay, so that 150 number is kind of a bright line, isn't it? Normal volume left means it's likely a support issue, but a high volume suggests a problem with emptying.
You got it. And to really pinpoint that support structure failure, the third test, or assessment really, is looking for urethral hypermobility.
Hypermobility. Why test for that specifically? Does it confirm the cause, or is it more about planning for potential surgery later?
It's a bit of both, actually. It helps confirm that the supports holding the urethra and bladder neck in place aren't doing their job properly. It involves seeing how much the urethra moves or angles downward during a strain, like bearing down. We used to use the Q-tip test for this, measuring the angle change, but now it's often done just by direct visualization or palpation. It's usually more comfortable. If that angle changes more than 30 degrees from horizontal, that's considered hypermobile and strongly supports SUI.
Okay, so that's the mechanical side. Now, let's shift gears completely. If SUI is structural, urgency urinary incontinence, UUI, sounds almost neurological. It's not about leaking with a sneeze. It's that sudden, intense urge that leads to leakage. Right.
That's the core of it, yes. It's often described as a key-in-the-door phenomenon. You feel fine, then suddenly you have to go right now, and sometimes you don't make it. It suggests the problem with bladder signaling or inappropriate bladder contractions. The bladder muscle, the detrusor, seems to be contracting or trying to before it's really full. When we look at the history for UUI, we often find potential triggers, things like heavy use of bladder irritants. Caffeine is a big one. Alcohol, too. Certain medications, like diuretics, can contribute. Or sometimes it's linked to underlying medical conditions that affect nerve control, like multiple sclerosis or spinal cord injuries.
And diagnostically, how do we pin down UUI?
Well, structurally, it requires two key negative findings from the tests we just discussed. You need a negative cough stress test, so no leakage with exertion. And, crucially, you need a normal PVR.
Yeah.
That tells us the leakage isn't from physical stress or because the bladder isn't emptying properly.
That comparison really helps frame it. Okay, and let's nail this high-yield point. The difference between UUI and overactive bladder, OAB. People mix these up all the time.
Oh, definitely. It's a great point. OAB is really the symptom complex, that feeling of urgency, often with frequency and maybe nighttime urination. You can have OAB without any leakage. So you have to ask patients, okay, you get that strong urge, but do you actually leak urine because of it? All UUI falls under the umbrella of OAB, but only the OAB that results in actual incontinence gets classified as UUI. It's a critical distinction for treatment.
Right, whether you just feel the urge or actually leak changes everything. Okay, now things can get even more complicated, can't they? What happens when symptoms overlap, or if the issue is purely about the bladder not emptying?
Exactly. That brings us to mixed UI and overflow UI. Mixed urinary incontinence, MUI, is pretty much what it sounds like. The patient has symptoms of both SUI and UUI. So they leak when they cough or sneeze, and they also get those sudden, strong urges that cause leakage. Diagnostically, you'd expect to see findings supporting both. A positive stress test, but still a normal PVR.
Okay, straightforward enough. Then there's overflow urinary incontinence, OUI. The symptoms here sound like the complete opposite of SUI. It's more about the bladder being too full.
Precisely. Patients report things like constant leaking or dribbling, feeling like they can't empty completely, needing to go frequently, maybe especially at night, nocturia, or just having a weak urinary stream. And this is where that PVR measurement becomes the absolute key. Unlike the other types, OUI is basically confirmed by an elevated PVR. If the bladder is holding on to significantly more than, say, 150 milliliters after voiding, that points strongly towards overflow.
Regardless of the stress test result.
Regardless, the high PVR is the defining feature here.
And what causes that excessive retention? Is it usually one of two main things?
Generally, yes. The clinical pearl on OUI mechanics is it usually stems from one of two underlying problems. Either the detrusor muscle itself is underactive, it's not contracting effectively to push the urine out, which we often see with nerve damage, perhaps from diabetes, MS, Parkinson's disease, or spinal cord issues, or the other cause is bladder outlet obstruction.
Obstruction. So something is physically blocking the urine from getting out, like severe pelvic organ prolapse, maybe scar tissue from prior surgery, or even a tumor.
Exactly. Anything blocking the exit path. And that's why, as you mentioned, the physical exam for suspected OUI often includes a careful neurologic assessment. We're looking for clues, particularly related to the nerves controlling the bladder, which originate in the sacral segments S2 to S4. Things like checking lower extremity strength and sensation, or the anal wink reflex, can point towards nerve issues causing that muscle underactivity.
Fascinating how systemic it can be. Okay, last category. Functional urinary incontinence, FUI. This one seems different because the urinary system itself is okay.
That's the defining characteristic, yes. In FUI, the plumbing, the nerves, the muscles, they're all working fine. The person is incontinent simply because something outside the urinary system prevents them from getting to the toilet in time. It could be severe arthritis, making it hard to move quickly or manage clothing, significant cognitive impairment like dementia, or even environmental barriers in some cases. Mobility and mental status are key here.
Okay, let's try and connect this back to the bigger picture now. We mentioned pelvic organ prolapse, POP, a few times. What really stands out to you about how POP interacts with UI? It seems complicated.
Oh, it is. What stands out most is how deceptive the relationship can be sometimes. POP definitely often coexists with UI, especially SUI, because they share risk factors like childbirth trauma or tissue weakness. But POP introduces this major diagnostic curveball, the masking effect.
Wait, hang on. So a physical problem like prolapse can actually hide the symptoms of another problem, like stress incontinence. That sounds like a potential diagnostic trap. Does that happen often?
It absolutely can happen. Imagine the bladder or urethra has prolapse, dropped down significantly.
Mm.
Sometimes that descent actually creates a kink in the urethra. That kink can physically block urine from leaking out during a cough or sneeze, even if the underlying support problem of SUI is present. So, if the examiner doesn't manually lift or reduce the prolapse back into a more normal position during the stress test.
They might mistakenly think the patient doesn't have SUI because they didn't see leakage.
Exactly. Or worse, they might see the patient struggles to void fully because of the obstructive kink from the prolapse, get a high PVR, and misdiagnose it as overflow incontinence. Manually reducing that prolapse during the exam is a critical step to unmask any underlying SUI.
That's a really crucial point for accurate diagnosis. So it sounds like for most people, the standard office evaluation, history, exam, maybe a voiding diary or a questionnaire is usually enough to start. When do you need the more complex, specialized tests?
Yeah, the basic office workup is often sufficient, especially for straightforward SUI or UUI. The complex tests like multi-channel urodynamics or cystoarthroscopy, where we look inside the bladder with a camera, are generally reserved for specific situations. Maybe the diagnosis is still unclear after the initial evaluation, or perhaps the patient hasn't responded to initial treatments as expected. Or critically, if surgery is being planned, these tests can provide much more detailed information about bladder function and anatomy.
Okay. And just to round out the diagnostic possibilities, if you go through this whole evaluation pathway and everything still seems negative or unclear, what are some other less common things clinicians might consider?
Good question. If the standard workup is unrevealing, you'd start thinking about less common structural issues. Maybe a fistula, like an abnormal connection between the bladder and vagina, a vesicovaginal fistula. Certain medications can sometimes cause incontinence as a side effect. Or rarely, something like a urethral diverticulum, which is an outpouching of the urethra.
All right. Got to keep those in the back of your mind. So wrapping this up, what does this all mean for you, the listener?
I think the key takeaways are just how common UI is and the absolute necessity of a structured diagnostic approach. You always start with that triage, clear pregnancy, clear infection.
Mhm.
Then you systematically work through the types, really focusing on distinguishing SUI, which is about exertion, and typically has a normal PVR, from UUI, which is about that uncontrollable urge, also usually with a normal PVR.
Mm.
And remembering OUI is defined by that high PVR. And thinking about that complexity, especially the prolapse example, maybe it raises a broader question for you to ponder. If a physical issue like a prolapse kinking, the urethra can effectively hide a physiological problem like stress incontinence. What other seemingly unrelated physical conditions or findings, maybe things you see on a routine exam, might actually be masking or altering the symptoms of completely different underlying issues? It's something worth keeping in mind as you encounter complex patient presentations in the future. How things interconnect isn't always obvious.
A really complex system indeed, demanding that careful, step-by-step evaluation. Thank you for joining us for this deep dive into evaluating urinary incontinence. We really hope you feel much better equipped to understand this incredibly important yet often hidden health challenge.